So I'm going to do the last session today on alcohol hepatitis. I want to first introduce the panelists for my session, and that would be Drs. Yanni, Choi, and Ben Hamoud. These people have done research on alcohol hepatitis, so I'm excited that they'll be joining us with me today. In the next 25, 30 minutes, we want to cover three very important objectives. We want to demonstrate the increasing public health concern of alcohol hepatitis, and why are we talking about this right now? Where this wasn't part of our mission statement, just a couple of years ago. We're going to talk about prognostication and treatment of alcohol hepatitis, and then look at a very important topic of assessing the role of liver transplant in the management of alcohol acute hepatitis. And this is a big paradigm shift for all of us in academic and transplant centers. So we're going to start with a case, like my colleagues have did previously. This is a 40-year-old gentleman admitted with a diagnosis of cholecystitis. And this gentleman was admitted to an outside facility for abdominal distension and severe abdominal pain. And an ultrasound noted distended gallbladder with some sludge, mild wall thickening, and perhaps a Murphy sign. The gentleman also had an ultrasound, and the ultrasound actually showed a fatty liver with some nodularity and possible thickening of the genital loops, possible enteritis. So this gentleman was started on antibiotics for suspected cholecystitis, and there was ascites on imaging, but not enough to tap. The HIDA scan showed biliary dysfunction, but no signs of obstruction. Patient saw the general surgeon and who consulted, and he had concerns, but because his underlying liver disease, he didn't want to do any intervention and transfer use of further care. So here are his laboratory tests. I'm going to invite my colleagues to comment on the laboratory tests. And I want to pick on my colleagues. And Jihan's the first on my gallery view here. So Jihan, what do you think about his blood test? Anything draw your attention? Anything concerning?
Yes, they're mostly all abnormal.
Great answer.
So, the leukemoid reaction of 35 is really concerning. The low platelet count, clearly the INR, he has evidence of synthetic dysfunction with a low albumin. And the total bilirubin of 11, obviously you start to suspect potentially alcohol use, starting to sound like acute alcoholic hepatitis potentially. And the creatinine is also a big concern. When I start to see creatinine jump in these patients, I get really worried.
So our fellow took a history, and this guy said he drinks about 4 beers a day on the weekdays, and a lot more on the weekends. And about 9 months ago, during the COVID pandemic, he started asking whiskey to his regimen. I know, Jihan, you try to publish on this area about how our drinking habits have changed during the COVID pandemic. And in October, woke up one day feeling hungover, decided to stop drinking, and he stopped smoking that day. But a review of the notes suggested kind of a different history, Jihan. It suggested he stopped drinking not because of hungover, because he had alcohol-induced pancreatitis. No history of any bleeding, no encephalopathy, and on examination, Gina, he's found to have 3+ pitting edema. So he's transferred, he's been afebrile, he's got a little tachycardic, and his abdominal pain has improved. He's now on antibiotics, and of course, he's on diuretics. And Gina, he had a blood test came back that really changed, our concept of what's going on. What do you think that test could have been?
A PEth test.
A PEth test. So we're going to talk about PEth test very soon, but it's a test that did lead to a change in our direction. So, Dr. Yanni, you're also an expert right now on alcohol hepatitis. I know you published a couple articles on this that have been well received. So, Dr. Yanni, this patient comes to your office, or you're a hospital, and like Jihan said, he's got a high white count, high bili. He's got a liver, show fatty liver and a nodularity. Gina's concerned this guy's got a positive PEth test. What do you do? Do you send him to the operating room to take his gallbladder out? You talk about transplant evaluation. This guy's pretty sick, but there's some question about his history now, about when he stopped drinking it. Or do you start corticosteroids on this gentleman?
Yeah, so the cholecystectomy part is a definite no. So I agree with our surgeon colleague. It's a very smart decision. The HIDA scan would probably show a low ejection fraction because of the high bilirubin. After a patient becomes visibly jaundiced around a bilirubin of 2.5 to 3, the HIDA scan loses a lot of its sensitivity and specificity. And cholecystectomy in this situation could actually worsen this patient's outcome with severe decompensation, so on and so forth. In terms of liver transplant evaluation, it's a possibility now, but it's a very tough question to answer because, if the patients have had recurrent relapses, have known about their disease process and continue to drink, and they don't have good. We have to evaluate their social support, their drinking habits, their risk factors. So multiple things here. There's definitely a possibility, but I would say maybe 1 to 2% of all comers would qualify for this. Corticosteroids, there are quite a few contraindications to corticosteroids. In this case, particularly, the patient has already started developing hepatorenal syndrome, a history of pancreatitis. We still don't have a full infectious workup result back. So I would hold off on corticosteroids at this point, given his state. But generally, corticosteroids therapy is considered in patients with a discriminant function over 32, which can pose a high mortality risk.
Wow, that's wonderful. So along those lines, I want to cover 3 topics for this group. One of them is distinguishing between acute on chronic liver failure from just simple alcohol hepatitis. And Dr. Yanni was alluding to, and Benhamu also, treatment options for alcohol hepatitis. And also talk about the role of liver transplantation with people with short duration of sobriety. So as you know, severe alcohol liver disease is a spectrum. On the one hand, we have alcohol cirrhosis, people drinking for many years and just have progressive liver disease. On the other hand, we also have alcohol hepatitis. And then we have this combination of acute on chronic. Now, Jihan taught me the past 12 months that there's actually a very specific definition of alcohol hepatitis that was put forth by ASOD. And it's listed here in these 4 bullet points that people need to have onset of jaundice within 8 weeks, alcohol consumption at least 40 grams in a woman, 16 a man for a day for 6 months, and 6 days of absence before the onset of jaundice. And in liver enzymes, and these are very strict definitions, AST more than 50, ACLT a ratio more than 1.5, and both have to be less than 400. So G and I have taken care of people in the hospital who come in with liver tests 1,000, and although there may be a component of alcohol hepatitis, is not strict alcohol hepatitis. It may be a component of ischemic hepatitis or DILI that's been brought before, and the BILI has to be at least 3. And then there's also a consortium that also has stratifies the certainty of alcohol hepatitis, and indeed the most definite diagnosis requires a liver biopsy, which we really never do because people, as Bishoy mentioned, are just so sick with high INRs, and low platelets sometimes. So a question comes up, about drinking alcohol. Jihan talked about there's her NAFL talk, and she talked about why the term NAFL is going away because you could have metabolic and alcohol fat liver at the same time. And this is what we consider safe drinking, and it's important to remember that, a can of beer, a glass of liquor, a table glass of wine, a short glass of distilled spirits, all carry around the same amount of alcohol. And alcohol is alcohol. And they all have around 14 grams of alcohol per unit. Dr. Yanni also mentioned that we have people with liver disease who want to stratify how sick they are. And this is important because this also lends itself to identify people who may benefit from corticosteroids. And we have a number of scoring systems, the MADRE, discriminative function. This is easy to calculate. It involves just 3 laboratory values: bilirubin, prothrombin, control prothrombin. We can use a MELD score, and that's been validated recently also to estimate prognosis. And in the Lilly model, and the Lilly model is a little bit different because the Lilly model takes place 7 days after corticosteroids. So it identified people who are on prednisone, corticosteroid prednisolone, and after 7 days of treatment, it identifies those people who are responding or people are not responding, and you should stop therapy right off. So Lilly's model is a little different in that the baseline requires people to be on steroids. Gina talked a little bit about the test that made a difference in patient care, and that it's a PEth test. This is a very sensitive and a very specific test. If you look for false positive, there are very few. I did a literature search on Friday to look at what false positive PEth test, and there's really nothing out there. Jihan, Gina, Bishoy, do you guys know of any positive things that give a positive PEth test in patients with cirrhosis or liver disease?
No.
The biggest paper I find 9 false positive, but they said in reality, when you take histories, when you look at other ancillary tests for alcohol consumption, there's really no false positive test. And the beauty of this, if this can detect excess alcohol consumption over the previous 3 to 4 weeks. So if someone says, I went to a big party New Year's Eve, and on March 7th, the PEth is still positive, it's probably, patient was probably drinking recently. Generally, PEth test by 3 or 4 weeks is close to zero undetectable levels. And this is kind of how we use PEth test in clinical practice. A PEth test less than 20 might suggest light drinking or actually no consumption over the past couple weeks. A value between 20 and 200 reflects significant consumption. So if you have someone who do a PEth test and the PEth test 180, this person has been drinking more than you would have thought. And a value more than 200, that suggests very heavy consumption. So in our center, we use this very selectively in patients who we think there is a difference in their clinical presentation and what they're telling us. Like this patient who was transferred for cholecystitis, the service did a PEth test and it came back very high, almost 200. And when we talked to the patient about the results, the patient became very aggressive with us. I started using a lot of 4-letter words. So now for our group, and Dr. Yanni touched upon this about the treatment options. And this is from a nice paper published a couple of years ago. And I know Dr. Yanni has expanded on this on another publication. But people who have severe alcohol hepatitis, and they have no infection, we're going to touch upon what Dr. Yanni said later about the kidney function. But we may talk about a course of prednisolone for 7 days. And after a week, we'll calculate the Lilly score and see if they're responding or not. So for my colleagues, Jihan, Gina, and Bishoy, do you guys use a Lilly score in your patients who you guys start prednisolone or any corticosteroids?
Yes.
Yes, definitely.
Yeah, absolutely. I think, I think there is a role for steroids in acute alcoholic hepatitis, but you have to be very strict about your patient selection. So as Dr. Yanni said, when the MELD is greater than 22 or the creatinine is going up, I don't think prednisone is going to help that situation at all. But if you do decide to bite the bullet and do it, you must check the Lil score, because if it's great, the number is, stop the Lil is greater than 0.56 or 0.45, that means you should stop, because then at that point, the risk outweigh the benefit. So I think it's crucial. I think the worst thing you could do is start steroids and walk away. You know, you have to start
Yes.
constantly keep on evaluating whether it's still indicated or not.
So, Jihan, that's a really good point, because sometimes when Jihan and me and you, Bishoy, see people in the hospital, they get discharged on prednisone. And so we've got to make sure that there's proper follow-up. Because, I reviewed the literature for this talk today, and I learned a lot about prednisolone. And one of the things that came across that you brought up is infections on prednisolone. It's a real concern. Would you guys ever use butosanide in these individuals with alcohol hepatitis? Gina, you brought up the issue about how it's safer and less side effects than prednisone.
Well, side effects like weight gain and acne and bone loss.
I know, but Shoy, would you ever use the synthetic butosanide in these individuals with alcohol hepatitis? And why not?
No, I don't use budesonide, and in fact, I don't use prednisone. I go directly to prednisolone because of the first pass effect. So, budesonide needs the liver to exert its effect, and we don't. The liver is effectively not working here.
Yeah.
And same with prednisone. There's a first pass effect. So prednisolone is usually what's used in practice.
Yeah, that's wonderful. That's wonderful. And that's the same reason we don't use in cirrhotic people with autoimmune hepatitis. Wonderful. So here's the data looking at a 28-day mortality and 6-month mortality with prednisolone. And you do see an improvement with corticosteroids versus control group and petoxifilin. Unfortunately, by 6 months, despite the positive effects of prednisolone in the 28-day, this is always translated to 6-month mortality. And there's maybe a lot of reasons. One is you might get them over the acute hump of the severe hepatitis, but like someone brought up earlier, you're not dealing with the underlying liver problem and also with drinking what led to the problem in the first place. Bishoy and Gina both very nicely brought up that we got to be selective of we use prednisolone in. And so we want to make sure that when we use it, people have uncontrolled infection. Most common was being urine, followed by ascites and pulmonary. Bishoy brought up very early on that that there isn't a lot of data on using prednisolone in acute kidney injury or GI bleeding, acute pancreatitis. It isn't that it may not work. We just don't know how safe it is in those settings. Hasn't been well studied. This is a very, very, very nice study that was published 3 years ago. And basically what it highlights, like Gina said and Bishoy, about follow-up is very important because people do better when they're on prednisolone and they're taking concurrent antibiotics. And it does suggest that what impacts mortality rate besides underlying liver disease, what impacts our long-term mortality rate is this risk of infection. So, I have a low threshold for starting antibiotics, particularly those individuals who have ascites. I don't know how you, Bishoy and Gina and Jihan feel, but I would not feel comfortable using prednisolone or any corticosteroid and someone's got ascites without being on some kind of prophylactic. I think you're asking for trouble. I think that ascites would be a nice for infection. Jihan, Bishoy, what do you think about that, about the role of antibiotics?
Yeah, I agree. Actually, you taught me that, Dr. Saab.
Oh.
If a patient has ascites, and I mostly worry about the discharge, because when they're in the hospital, you can watch them. But if you're going to discharge someone on steroids, you have to be very careful. And they usually have to be monitored at least weekly. And I would start prophylaxis if they had ascites.
Yeah, I totally agree. And so going back to Dr. Yanni's algorithm, so people who have probable definite alcohol hepatitis, and Jihan taught me this from the ASOD, if someone gets better, with prednisolone, we continue, and the steroids and look for response. And if people don't respond to medical therapy or they're so sick you cannot consider medical therapy, Dr. Yanni mentioned, what do you do? And at this point, you got to talk to a transplant center. You got to wonder and consider the role of of liver transplantation. So for audience, for Jihan, Bishoy, and Gina, what do you guys think about the role of liver transplant, alcohol hepatitis? Because let me tell you guys, I'm getting calls all the time from my friends at Harbor and Orange County and Downey, about alcohol hepatitis transplantation. What do you guys use in a few minutes, as a criteria for transplantation alcohol hepatitis in a few minute time? Because you could go on for hours on this. Jihan, we'll start with you because you're at the top of my screen.
Yeah, I mean, the first thing I do is, try to figure out if the patient has insight and understand why they're sick in the first place. I think that really drives the conversation. And I think what has been shown, if the patient is a transplant candidate and they go through the transplantation, then a history of uncontrolled psychiatric disease is important. Family support is extremely important, and social support. So, and their willingness to actually undergo rehab, which kind of ties in with their insight, is really key. Because we can transplant them, but the question is, the concern of recidivism post-transplant.
So, Bishoy, you're next on my screen. May I ask you also in like a minute or less?
Yeah.
I know you're an expert. You could go on for a long time. You're an expert in this area.
I completely agree with Jihan. I mean, we know that transplant offers the best survival for these patients, but insight and family support are the two most important things that research has shown will help these patients not relapse in the future.
Gina, any final points before I move on?
No, I think I absolutely agree.
So as Jihan said it, it's not like buying a car. There's a lot of steps involved: review, evaluation by distinguished team, discussion, and listing. And these are generally the accepted criteria for severe alcohol hepatitis, non-response to medical therapy. And you guys have all talked about prednisolone, why you like prednisolone. I think Jihan and Bishoy elegantly talked about the strong social support network. Insight to disease. I mean, do they know why they have liver disease, or like Jihan suggested, they're going to go back to drinking again? And and it's not fair to other people who are waiting for transplant. Not fair to the donor families either. The absence of coexisting psychiatric disorders, agreement to adhere to lifelong abstinence, and there has to be complete agreement by the liver transplant committee. This is a meta-analysis, and this is focusing only on two articles, so maybe more review. But clearly, in those individuals who don't respond to medical therapy, clearly survival is improved with liver transplantation over continual medical support. Clearly, this was shown in a landmark article 2011 published in the Journal of Medicine and reinforced in a recent publication in American Journal of Transplantation. But looking at the reasons why people are not considered transplant candidates, as my colleagues have said, the overlying reasons are not medical problems. The reason why people are denied for alcohol hepatitis have to do more with psychosocial. This is a summary of just 4 papers out of the whole medical literature. Only 4 papers have looked at reasons for denial. And you see that the most common reasons are going to be psychosocial and psychiatric. In contrast to non-alcohol hepatitis, where the most common reasons are going to be medical comorbidities. In fact, Gina Choi, one of our distinguished colleagues on this panel, has submitted a paper from our UCLA experience with Dr. Jihan also being a co-author, looking at the proportion of patients with social work and psychiatric reasons for liver transplant denial. You see here that the biggest reason for denial is going to be the lack of social support. Very, very sad. Imagine having someone who's 28 years old and no one willing to be a social support for that individual. So in conclusion, we're seeing now, and you see in your own hospitals, your own practices, that we're seeing a huge influx of young adults with alcohol-related liver disease. Gina brought up the issue PEth test, and their role in clinical practice. And this is a very accurate test for detecting chronic alcohol abuse in patients with who have a history of alcohol that's unclear. And 3 of our colleagues unanimously identifying new criteria that makes liver transplant available options, regardless of the duration of alcohol abstinence. So at this point, I want to thank you for your participation. And I guess give the podium to Dr. Akabani, who's going to lead us to the conclusion and the